Hello, how is everybody doing? Good, all right. So, welcome to the first video from this series. We are going to talk about general thoracic surgery. My name is Dobra Vlad Christian, and welcome to my YouTube channel. This is the first video where we are going to speak about some general aspects. First of all, I want to mention that I do not own any of the contents shown in the presentation. It's either pictures that I found on the internet or videos that we are going to watch together that I've taken from YouTube. I will mention the links in the description of this video. So we don't have any copyright issues. And this being said, let's go. First of all, there is a small problem that I've encountered quite often with thoracic surgery is that mainly people that are outside this field don't actually know what is about, and to make it more complicated, the situation is different in different countries. So for example, in some countries there is a separation and there are two specialties. First of them is general thoracic surgery that deals mostly with lungs, thoracic wall, diaphragm, esophagus, trachea, thyroid gland, mediastinal tumors, and has absolutely nothing to do with the cardiac surgery, which deals with the heart and the big vessels. In some other countries, there is a specialty that's named cardiothoracic surgery, and that includes both aspects of this surgery, the general thoracic surgery and also the cardiac surgery. Even in those countries, as well as I know, surgeons tend to specialize on either one of them because it is a lot of information. Both surgeries are extremely difficult to perform and it's a lot to learn, so it's quite difficult to perform both of them. A little bit here from this introduction. We'll jump over this, we'll get back to it in a second. But first, I will tell you a little bit about the most frequent encountered surgery in this field, which is the pulmonary resection. And as we can see in this, it can vary from a wedge resection to up to a pneumonectomy, which is the biggest pulmonary resection we can perform. And this is being done by cutting the vascularization of the lung, which is the pulmonary veins and the pulmonary arteries that bring and take blood from that portion of the lung that we want to resect, and also to be able to cut and seal the airway, the bronchus. So the ways of approach for this kind of surgery are three: open thoracotomy, video assisted thoracoscopic surgery, and robotic thoracic surgery, or ROTS. The open thoracotomy is still being used a lot. It comes with bigger post-operative pains and also with longer length of hospitalization, but it comes also with reduced costs. The second one is VATS, or video assisted thoracoscopic surgery, which can be performed through multiple ports or through one port through which we insert the camera and the working instruments, and we will be watching videos of all three in the next videos. And also, of course, using the robot, the RATS, or robotic thoracic surgery, which is the latest, the newest, and it is not available in all the centers. But to sum up, these are the ways we approach the surgeries. Good. Now we can deal a little bit with what we are going to watch pre-operatively when we are dealing with a patient that is going to undergo thoracic surgery. So first of all, we need to perform pulmonary function tests to be able to see if the patient, for example, after a resection, will be able to maintain his respiratory function with the lack, together with the lack of the tissue, the pulmonary tissue that is going to be resected. Of course, the evaluation of the cardiac function, because surgery itself it's a pathology, and we need to make sure that the patient will resist this stress, and we need to check the coagulation status of the patient and stop certain medication a few days prior to the surgery. We will get into detail about this aspect in another video, and to check, of course, the other comorbidities if they allow us to be able to go in the OR with the patient. We need to check this first, the anesthesia, the anesthesiologist also, and give or not, allow or not the patient to be operated. All right, so talking about here, we have this little problem or little difference when we compare to other specialty or other surgical specialties. The intubation is being performed with double lumen tube. One is tracheal, one is bronchial. We have two balloons that are being inflated. I will let the specialist explain it better to you. I took this drawing from a YouTube video that I will leave the link for in the description. Here it is explained really well for those of you that want to enter in details about this. The main idea about this is that we need to ventilate on the other lung, the healthy lung. The lung that we are going to perform our surgery on needs to be deflated, and this will be done with the help of anesthesia, with the help of double lumen intubation. So also I will leave the link for this video as well.
So we hook up our adapter, then we inflate our cuffs here. So we put some air in the tracheal cuff.
This is the tracheal cuff.
And then we put some air in the bronchial cuff, and you really want to put 2 or 3
And also the bronchial cuff. So
Now
when we are
once you can verify that you can ventilate the patient, we need to check to see whether or not this is correctly placed. So first method is auscultation. So to do that, you need to clamp one of the lumens. So here I'm going to clamp the bronchial lumen. So if this is correctly placed,
this is being done using a stethoscope. So they are clamping one of them, and then they are listening to the lung, to the lungs, just to see where they can hear the lung sounds.
you should only hear breath sounds on the right side. And you can see that that's true. Like you can only hear it on the right side. And then if I want to go ahead and clamp the tracheal lumen, I should only hear breath sounds on the left side. And that's the case. The second way of verifying correct placement of the double tube is to use a fiber optic bronchoscope.
This is being done in most cases. They are having this fiber optic bronchoscope, and they are just checking the placement, the correct placement of a double lumen tube.
And the best way to do that is to open this cap to the tracheal lumen, and we're going to insert this scope down into the tracheal lumen and look at the level of the carina. So as we're advancing the scope down the tracheal lumen, we're eventually going to come to the carina. And it looks like that's carina right there. We can see that the right minimum is
This is the carina, left and right bronchus, so it is intubated correctly on the left side. Good. Also, the insertion can be performed using the fiber optic bronchoscope just to make sure that you are placing it in the right position. And this being said, I think that's it for today. So until next time, make sure you subscribe, you like, and you share this video with your friends so we can learn and grow together.